Right?
Yes.
Okay, so today I will be talking about infratentorial and supratentorial craniotomies. As Dr. Adrian mentioned, all approaches and management of different surgical lesions differs from country to country. So I will be strictly point to, okay, why I'm not able, okay. I will be strictly talking about more classical approaches. So craniotomies are named on the basis of their corresponding bones and anatomical landmarks. Depending on the location of pathology to be addressed, we have supratentorial and infratentorial posterior fossa craniotomies. Okay. Frontal craniotomy can be unilateral and bifrontal. It gives access to the frontal skull base, approaches to the third ventricle, cellular tumors, craniopharyngiomas, plenum sphenoidale meningiomas, frontal lobe tumors, repair of the CSF fistulas. Placing the borehole on either side of the anterior superior sagittal sinus, extending craniotomy to about the mid-papillary line, and turning the drill to extend the craniotomy as anterior as allowed by the margin of the periorbital flap. Pterional craniotomy, also frontotemporal sphenoidal craniotomy. It is a workhorse craniotomy which gives access to frontal and medial cranial fossa. The most important thing is a keyhole borehole allows to access to the both frontal and medial, anterior and medial cranial fossa. The second borehole should be placed at the level of the temporal squama above the posterior root of the goma, and sometimes you can put the borehole at the superior temporal line. And as you see, the numerous and big amount of the lesions that can be accessed through that approach, to that through this craniotomy, and we all owe to Professor Ghazi Yazargil for this invention. Parietal craniotomies are applicable for falcine meningioma. Specific placement depends on the location and the size of the tumor, as well as the surgeon's preference. Boreholes are typically placed near the midline and around the superior sagittal sinus. The medial cut should be made last in the case of tear of the superior sagittal sinus, so that the bone flank can be removed quickly to achieve hemostasis. Midline occipitoparietal craniotomy that applicable for tumors along the falx cerebri, tumors above the tentorium cerebelli. Medial bone cut must be on the superior sagittal sinus, and the inferior cut should extend to the top of the transverse sinus and lateral to the sigmoid sinus. In this way, there will be less retraction of the occipital pole. If there is a significant hyperostosis, it is the best to use high-speed drill with the diamond bore. So temporal craniotomy, when a patient has temporal lobe, needs temporal lobe biopsy, either requires temporal lobectomy, temporal lobe epilepsy surgery, other tumors. So the borehole at the anterior limit of the exposure immediately superior to the zygoma root, at inferior posterior aspect of the exposure just above the supramastoid rest, below the highest points of the squamous suture. Alternatively, that can be put either one borehole or two boreholes. Again, it depends on the surgical preferences and of the experience of the surgeon. Lateral suboccipital craniotomy, also called as a retrosigmoid craniotomy, well-novel craniotomy for all young neurosurgeons and residents, and which can give us access to the cerebellopontine angle, vestibular schwannoma, CP angle tumors, MVD for hemifacial spasm, and so on. The initial borehole is typically placed just medial to the sigmoid sinus and inferior to the transverse sinus. The asterior can also be used as a reference point for borehole placement. Aneurysms for vertebral-basal junction can be used by two different incisions. As you see on the illustration, bone removal must be extended from the junction of the transfer to sigmoid sinus. Down to the foramen magnum, removal of the medial third of occipital condyle should be performed, and hemilaminectomy of C1 should be also performed. Midline suboccipital approach is applicable for Chiari malformations. The craniotomy should be extended rostrally 1-2 centimeters below the torcular and transverse sinus, and laterally 1 and 1.5 centimeters from the sigmoid sinus. At the foramen magnum, bone removal should be carried lateral to the occipital condyles. Laminectomy of the C1 should be performed perform, and depending of the extent of the tonsillar herniation, which can happen in pediatric population most of the time, it may be necessary to perform additional cervical laminectomies. Suboccipital supracerebellar approaches, which we most of the time use for pineal region tumors, bone removal extend rostrally to expose 5 millimeter of the torcular and transverse sinus, laminectomy of C1, and the head maximally flexed so that the tentorium cerebelli should be parallel with the surgical line of the site. Medulloblastoma and ependymoma. So the patient hand should not be flexed as for supracerebellar approach. Bony removal is similar to as for Chiari malformation decompression, and in addition of removing posterior rim of the foramen magnum, performing a laminectomy of C1 vertebra is important. Foramen magnum tumor, similar for as Chiari malformation. In a foramen magnum tumor, the extent of cervical laminectomy is determined by the caudal extension of tumor into the cervical spinal canal. It is not necessary to expose bone up to the torcular or lateral to the sigmoid sinus, and it is necessary that the bony removal extend to the occipital condyle on the site of the tumor.